Welcome to Menopause Rescue. I'm Dr. Polly Watson. Midlife women are often caught up in a sea of symptoms. Too often, they're overwhelmed by the lack of support from mainstream healthcare. They're inundated with so-called experts who are selling solutions which may lack credibility. I'm a Menopause Society certified gynecologist with both traditional and functional medicine training. I'm here to guide you through this transition and help you decipher the facts from the fads. Armed with credible information, I hope you are empowered to rescue and restore your health, making the second half of your life your best. Welcome to Menopause Rescue. I'm your host, Dr. Polly Watson. Does HRT have an expiration date? I would argue no, but so many women come into my office and literally have the rug kind of pulled out from underneath them with their health when their healthcare provider says, oh, it's been 5 years, it's been 10 years, whatever the number of years is, I can't prescribe this anymore. The carriage has turned into a pumpkin, and all of a sudden, without warning, they're off their hormones. And oftentimes, these women are really suffering. And they end up in my office, and we're revisiting this question of, do we have a time limit for staying on hormone replacement therapy? So that's what we're going to talk about today. I think this is going to be really helpful for so many of you, and I hope it can give you some framework to help have a more thoughtful conversation with your healthcare provider so that you can get the care that you deserve. So, a lot of folks in the healthcare world really haven't had adequate training in menopausal medicine. And, understandably, healthcare providers are burnt out. Ever since the advent of the electronic health record, healthcare providers are taking home 2+ hours a night of clicking boxes so that a bean counter from the insurance company will tell them whether or not they got paid for their day's work or not. So, not to try to throw conventional healthcare providers under the bus here. It is really tough being out there on the front lines, and healthcare systems are asking doctors and mid level providers to do more and more for no pay on their free time, answering portal messages, refilling prescriptions. They're not paid for any of that. So, I just want to start off with some grace for these folks on the front lines that are really helping all of us. But many healthcare providers didn't get great menopausal medicine training, or they haven't really had the time or the bandwidth to update their training since the Women's Health Initiative. So, we're going to dive in and talk a little bit about how these attitudes on how long to stay on hormones have changed since the Women's Health Initiative over 20 years ago and what they look like now. Okay, so most of you are probably familiar with this study, the Women's Health Initiative study. It came out in the early 2000s, and the study was stopped prematurely. It was done on one formulation of hormone replacement therapy, which was conjugated equine estrogen, Premarin, and a synthetic progestogen called medroxyprogesterone acetate. And in the women who were in that arm of the study, that were on both the basically a pregnant horse pea urine estrogen and the synthetic progestogen, they found a very slight bump in breast cancer after the first 5 years. And so that's where this magical number of 5 years kind of originated, where we're not going to continue treatment after that. Since the WHI, we have revisited this study. The age of women in the study was often much older than we start women on hormone replacement therapy. And then we've also learned that the type of progestogen really matters for breast cancer risk. And maybe we've also put that breast cancer risk into a little better perspective. So 3 more women out of 1,000 over 5 years had an increased risk of breast cancer. That's about increasing your breast cancer risk the same as if you were to drink 1 to 2 glasses of wine a day. So there was a slight bump in breast cancer on that specific formulation with the synthetic progestogen, the medroxyprogesterone acetate. Interestingly, in the women who'd had a hysterectomy who got estrogen only, there was no bump in breast cancer. And we've seen this again and again in the Women's Health Initiative and the Nurses Health Study and the Million Women Study. We've seen lots and lots of data that estrogen alone doesn't seem to bump up breast cancer risk, that adding a progestogen to it, a chemical that looks and acts like progesterone but is not bioidentical progesterone. So some of those examples would be norethindrone, medroxyprogesterone acetate, levonorgestrel, etc. All those have been shown to show a very slight increased risk in breast cancer. And in observational studies in women who are using bioidentical progesterone, we don't seem to see the same bump in breast cancer. We can never tell someone there's no breast cancer risk, but I think that using a micronized bioidentical progesterone that you can get through as an FDA approved product is much safer on the breast and then allows us to have a lot more open conversation about duration of use. Back in the early 2000s, that's where that first, you can only be on this for 5 years came from. Okay. So the first kind of statement from the Menopause Society around that time was we use the lowest and most amount of hormones for the shortest amount of time. And that's where a lot of people have, a lot of healthcare providers have kind of gotten stuck, where there's this time limit on hormone replacement therapy use and there's an expiration date. Maybe about 10 years ago, Menopause Society said, we're going to use an adequate amount of hormones for an adequate amount of time. And now the Menopause Society is saying benefits outweigh risk very clearly for the first 10 years of use. And beyond that, it's personal decision making. So, what we're trying to move towards is personalized medicine, taking a look at someone's risk and benefits and helping partner with them to help them make a decision that's best about how they should move forward, and getting away from this idea that everybody is treated exactly the same. There is an expiration date on your hormones. And, when you go in at year 5 or year 10, um, these prescriptions cannot be refilled. That is not really backed up by the current recommendations by Menopause Society. It's not backed up by current science. And unfortunately, a lot of our healthcare providers, just who are doing the best they can, getting through their days with 30 patients back to back, they haven't had a chance to update their training. There are two more really important concepts that I want you to walk away from today. And one is that then this has also changed over the last 20 years. I remember going to Menopause Society as a very young doctor and being told that menopause lasted for 4 years, the symptoms lasted for 4 years. And that was over 15 years ago. And now we know from the study of women's aging across the nation that menopausal experience can vary widely among people. And so women who are between 60 and 65, 42% of women in their 60s are still having hot flashes and night sweats. So, if we're in this kind of expiration date, anxious mindset, we're leaving at least half of women, or almost half of women, still being really pretty significantly symptomatic in their 60s and not addressing their concerns. If we look into the 70s, we see that 10 to 15% of women are still having hot flashes and night sweats. So, this idea that once you're 60 or once you're 65, you're no longer having to manage menopausal symptoms is just simply not true. So, as we're moving towards this more personalized, hopefully creating a partnership between healthcare provider and patient, we're also expanding our understanding or updating our understanding that menopausal symptoms don't necessarily stop at a certain age for everybody. We have women that we call super flashers. Isn't that awesome? Can't you imagine this woman in a superhero cape? That's how I'm imagining a super flasher. That will have symptoms through the end of their life. They will never stop. And this could be 12, 13% of women. So let's not leave these women out in the heat rather than out in the cold, I guess. So as we expand and update our understanding of menopausal experience, let's make sure everybody's experience is addressed. The second kind of big shift that I want you to be aware of is the idea that we take hormone replacement therapy for hot flashes, night sweats, osteoporosis prevention, and vaginal dryness. That is kind of what these medicines were FDA approved for. And in the last 15 or 20 years, we've really expanded our understanding and continuing to explore the effect of hormones on mood, the effect of hormones on neurocognitive health, the effect of hormones on bone and muscle health. And so I think we're having a shift from we're only treating your hot flashes, and when your hot flashes are over, you don't need this anymore, to we're promoting your health span. And we know that continuing your hormone replacement therapy is absolutely going to protect your skeleton. And we know that stopping hormone replacement therapy is absolutely going to withdraw that support for your skeleton and can significantly contribute to osteoporosis. So we're shifting this idea that we're only using hormone replacement therapy for hot sweats, night sweats, and hot flashes, and night sweats, and vaginal dryness. And now maybe thinking about it from extending health span, extending the time of our lives where we are feeling vital and healthy and are active, and acknowledging that quality of life piece that hormone replacement therapy so dramatically supports for many, many women. So when I'm meeting with a patient who's, let's say this patient's 65, when I write a hormone replacement therapy prescription and someone has Medicare, it's really interesting. I could write a narcotic, y'all, and the EHR does not come back with this warning label. You're about to prescribe an addictive substance. Stop. No. But when I try to prescribe estrogen to someone who's over 65, the computer gives me this warning that says you're prescribing a high risk medication, and it just makes me crazy because there's so many higher risk things that I could prescribe, and I feel like bias against really addressing women's quality of life is so entrenched in medical practice that it's unbelievably frustrating. So, I guess I just want to also kind of throw some compassion if you are a patient and your healthcare provider is really pushing back against you because you're 65 and you want to continue your hormones. There is a lot in their electronic health record that's saying, hey, stop, don't do this. Wait, throw on the brakes. I have to click a specific button that allows me to continue to write the prescription. The default is for me to stop writing the prescription. And so there's a lot of systems in place that makes this harder for folks to get what they need. Okay, so someone 65, they come into my office. They've been doing well on hormones for, let's say, 13 years. Let's say they went through menopause around 52. Maybe they started hormone replacement therapy around then. They took advantage of protecting their bones and their heart early in the menopausal transition. And they're at my office because their family practice doctor or whoever's taking care of them said they will no longer continue to write for hormone replacement therapy. And they're wanting to know what their options are and where all this is coming from. So, what's going on in my brain to help them make a decision? What kind of questions am I asking? What do I want to know about? One of my huge concerns is bone health. If you fall and break your hip in the United States, there's a 22% chance you will be dead in 12 months. That is an astonishing statistic. Coupled with that, we know that if you were on hormone replacement therapy, we have protected your bones. And we know that protection basically goes away after 2 to 5 years off hormones. Okay. So, absolutely 1,000%. We want women lifting weights. We want women eating adequate protein. We want women walking on different terrains and practicing balance. We're not saying just take hormones and go sit on the couch and not do anything for your skeleton. But hormones can be a really essential part of that complex puzzle that we're putting together to support musculoskeletal health as we age. So, one of the questions that I'm going to ask that person is, do you have a family history of osteoporosis? And what was your diet and lifestyle like when you were building your skeleton? So we know that we're building our skeletons roughly through our adolescence to our kind of mid 20s, maybe up to 30. Okay. So if someone says, I had an eating disorder, I was a ballerina, I really restricted my food, and I was significantly underweight. And when I was building my skeleton, I was really nutrient poor. I'm going to be much more concerned about taking that person off her hormone replacement therapy than someone who says, no, man, I ran track, I did pole vault, I did the long jump, I ate great, I've always taken really good care of my body and have been strong and healthy. That person has built a much stronger skeleton going into this time of their lives. Obviously, we would take into account if we've got a bone density test. If we don't have one, we'll get one. But what is the state of their bones on hormones? Where are they? Do they have any room to lose some bone, or are they already suffering from osteoporosis or osteopenia? I also want to know about their family history in terms of neurocognitive decline. And we're still learning about this. So I want to qualify all of this by saying that we are still learning about estrogen being protective for the brain. And there is probably some nuance here. So, women who have hot flashes are a cardiovascular disease risk. If we don't have healthy blood vessels on our heart, we're not going to have healthy blood vessels on our brain. And that population of women who are symptomatic with menopause may be especially vulnerable for neurocognitive decline, and they may look different in terms of getting benefit from staying on hormones than women who never had symptoms. So I think that we're still learning about this, but there may be certain groups of women that we really need to make sure that we study, in particular those women that are symptomatic. So if someone comes in and says, I already have osteopenia, I already have osteoporosis, I had, maybe they were a bookworm, maybe they didn't exercise very much when they were building their skeleton, and they've always been a relatively sedentary person. I'm going to be much more concerned about withdrawing their estrogen support for their bones than someone who's got great bones. Their bones look 20 years younger than they are right now. They're on a fantastic weightlifting program and they eat adequate protein. So we're going to look at all those things together. And then sometimes we also think about partnering with this patient and identifying what their concerns are. So, do they have bone concerns? If they start weaning down their hormones, a lot of times they'll say, you know what? It's not hot flashes that is coming back, it's anxiety. Or they'll say, my sleep quality was a lot better on hormones. So instead of kind of thinking about going off hormones as a black and white decision, sometimes part of this conversation when we partner with women, we want to know their family history, we want to know their current health concerns, but we also maybe don't think about jerking them off the hormones immediately. Maybe we drop their dose by half. How does that feel, right? Do you notice a difference? What what does that feel like in your body? Because I certainly have had a lot of women that have come back and not said it's the hot flashes and night sweats that come back, but oftentimes, you know what? This buzzy anxiety feeling that I remember in early menopause is back. Maybe we should consider revisiting this issue. Another thing that was published in the last year was this concept of the musculoskeletal syndrome of menopause. So, we want women to go to the gym and lift weights to protect their skeleton, but we also know that we need estrogen for muscle repair and regeneration. And so, if someone says, you know what, we went down on my hormones and I am not recovering at the gym, or I went to take care of my grandchildren and we were much more active and I was running around after 2 or 3 year olds and I'm in bed the next day in pain, or my frozen shoulder came back, that might be another reason to continue to stay on hormones that we're not really talking about. This conversation has really been framed in terms of night sweats and hot flashes. And there's so much more that we need to consider. One thing that I really want to emphasize, because inevitably, as we're having this conversation, the risk of breast cancer comes up. And we never want to minimize someone's breast cancer experience at all. We do know that when women are receiving hormone replacement therapy, the death rates of dying of breast cancer on hormone replacement therapy and the death rates of dying of breast cancer off hormone replacement therapy are flat. Okay. We know that women who are getting hormone replacement therapy are in the healthcare system, they're getting regular screening, we're more likely to catch them sooner, diagnose and treat their disease than folks that aren't in the healthcare system. I think another misunderstanding is that the hormones are causing the cancer to grow from the beginning, to sort of start cancer. And the truth of the matter is probably we all have some cancer cells running around in our system that our immune system is taking care of. And if we have a pre-existing cancer and we're taking hormones, it may speed up the growth of that cancer to the point that we can see it, treat it, and detect it faster. So I never want to minimize someone's breast cancer experience and say, well, the risk of dying from the breast cancer is the same whether you take this or you don't, so it doesn't matter. That's not my intention. I think that would sound really unkind. We know that a lot of people really struggle through that treatment and living that experience. But I do think it's important for people to understand that hormone replacement therapy isn't making cancer be born, if you will. It's probably speeding up the growth of a pre existing cancer that was already there. So, my hope in having this conversation is to broaden how we're interacting with this, let's say, the 65-year-old patient who's trying to decide if she wants to stay on hormones or not. I think so much of the conversation has been siloed in breast cancer risk. Is this acceptable? Yes or no? And what I would like us to consider is opening the conversation up and looking at her health span, looking at her quality of life, looking at her sleep quality, looking at her osteoporosis risk, understanding that we don't know everything about neurocognitive risk, but that there is some pretty great data saying that estrogen is good for your brain, particularly in women who have vasomotor symptoms. So, how can we have a nuanced and complex conversation that's respectful, looking at all of the areas of this woman's life and also taking into account the quality of her life? So, how we've thought about the sort of expiration date on hormone replacement therapy has changed. We used to say use the smallest dose for the shortest amount of time. And now we're really in an era of personalized medicine and shared decision making. This is not brand new. This is the 2022 Menopause Society position statement, which is open access, which you could share with your healthcare provider if you're getting a lot of pushback on this. We know that the mindset around managing menopausal symptoms has also made a big shift from just thinking about hot flashes and night sweats and vaginal dryness to thinking about health span, thinking about bone health, taking into consideration this very significant risk of mortality if we were to fall and break our hip. So I hope I can leave you with a little bit of hope and optimism that we are in a time of partnering with women and understanding what their goals are, that you do have options. You don't necessarily have to go off this at a certain time. I'm 51. I've been on hormones since I was 40. I have no intention of going off my hormones ever. I feel a lot better, and I have really significant osteoporosis in my family, and I have significant neurocognitive decline and Alzheimer's in my family. So, given that family history and given how much better I feel on hormones than not on hormones, I don't want to mess with the experiment. I feel good on this. It's working well for me. I have no intention of going off. So I would argue that hormone replacement therapy does not have an expiration date. And I would encourage you, we will link it in the show notes, to take a look at the NAMS 22 position statement on the use of hormone replacement therapy. That can be a great document to share with your healthcare provider if you're having a hard time with this conversation. Thanks so much for listening. Thanks for listening to Menopause Rescue. We hope you've enjoyed this podcast and it helps you create some time and space to make this the best half of your life. If you've enjoyed this content, please leave us a 5-star rating and review. This helps other listeners find this resource and rescue and restore their health. If you enjoyed this topic and want to learn more, check out our resource guide for this episode. If today's podcast resonated with you and you want to take a deeper dive, check out my educational resources. We offer basic membership, which is an archive of over 100 videos on menopausal topics ranging from bone health to libido. We add to this archive every month, so the resource becomes richer and richer over time. If you're looking for a menopause expert and live in North Carolina, take our free online class and see if we're a match for your needs. It's called Are We a Good Fit? And is a quick and easy way to learn more about our practice and what it has to offer. Hey, this is Dr. Watson. This is just a friendly reminder that this podcast is for general information purposes only and does not constitute the practice of medicine. No doctor-patient relationship is formed, and any information you get from this podcast is considered educational only. You should make medical decisions with your healthcare provider. The content of this podcast is not intended to be a substitute for professional medical advice. Listeners should not disregard or delay in obtaining medical advice for any medical condition, and they should seek assistance from their healthcare professionals.